Now we're going to do drug reactions, the neurologic ones. A patient comes to your emergency room with hearing loss, a ringing in the ears, which we call tinnitus, and blurred vision. You see in the chart that they have a rather extensive cardiac history, and for some reason, they're still on quinidine. What condition does this patient most likely have? So this trio of deafness or ringing in the ears and blurred vision, in the setting of quinidine use, we call synchonism. Quinine, Q-U-I-N-I-N-E, is the less potent enantiomer, or basically brother, of quinidine. In fact, both of them are derived from the cinchona tree, hence the name synchonism for this combination of symptoms and signs. The anti-psych medications, particularly reserpine, are notorious for causing and Parkinson-like syndrome. But why would an anti-nausea drug called metoclopramide be included along with the antipsychotics? All these are notorious for causing potentially tremor, rigidity, bradykinesia, and postural instability. All of these have a common thing in mind: dopamine receptor antagonism. Let's look at this diagram from your book. Remember that Parkinson's syndrome is due to the death of dopamine secreting cells in the substantia nigra pars compacta. This leads to a decreased dopamine stimulation of D1 and D2 receptors in the putamen, or the striatum. The decreased stimulation of these dopamine receptors leads to dysregulation of the direct and indirect pathways that allow us to facilitate or inhibit movement. The doctor term for this problem is a dyskinesia, and bradykinesia means slow. Now, dopamine antagonists, particularly antipsychotics and metoclopramide, can produce a Parkinson-like syndrome because they mimic the pathophysiology of true Parkinson's disease, which is what? Decreased stimulation of dopamine receptors. Notice how the same drugs, antipsychotics and metoclopramide, are listed as potentially having tardive dyskinesia as a side effect. Now, the classic presentation is a schizophrenic patient with abnormal movements of the face or the tongue, such as intense yawning, weird snake-like tongue movements, or lip smacking. So someone with poor manners that's eating at the table, basically. Now, with chronic, this is important, chronic use of antipsychotics, there seems to be more of a D2 than D1 antagonism for unknown reasons. So basically what I'm saying is that we're preventing the indirect pathway more so than the direct pathway from doing its job. So basically we're unable to properly inhibit movement because of the chronic use of antipsychotics or the chronic use of metoclopramide. With this in mind, it makes sense why you see the abnormal undesired movements such as the face moving or tongue smacking and grimacing. Now let's move on to seizures, starting with isoniazid. Isoniazid shares a similar structure to the active form of vitamin B6, which is pyridoxine. The active form that we actually use is pyridoxal 5-phosphate, P5P. This is the true active form of B6. Notice the similarity between the two. Check these things out. They look really similar, don't they? Pyridoxal 5-phosphate is required for the conversion of glutamate into GABA. Because isoniazid will bind to the enzyme and prevent this real cofactor from participating in the reaction, we do not have any production of GABA because isoniazid, it looks so similar to the B6 that it just slips in there and inhibits the reaction from happening. So essentially there's inhibition of enzyme, no creation of the inhibitory neurotransmitter GABA. So we're losing the inhibitory element of having GABA around. The brain now has decreased amounts of GABA available, which means that there will be less chloride influx into neurons, which means that now our resting membrane potential is a little bit strange. We're going to increase resting membrane potential of neurons more towards threshold. So now your patient is more susceptible to having a seizure. Anytime examiners can toss in biochemistry like this, you better be ready. Imipenem cilastatin increases the risk of seizure because this directly inhibits GABA receptors, while enflurane has been shown to decrease responsiveness of neurons when GABA binds for unknown reasons. It is not yet completely understood why bupropion or tramadol actually decrease seizure threshold, What's important to know that is that bupropion is something that a lot of people get for depression, and you have to remember this. Just memorize it. Two main drugs that can cause diabetes insipidus include lithium and dimethylcycline. Now, both of these drugs inhibit intracellular response of the principal cells within the distal collecting tubule. When vasopressin binds the V2 receptor, it is thought that both of these drugs somehow inhibit adenylyl cyclase from responding properly. Notice that the V2 receptor signals through a G-stimulatory protein. What happens when there is decreased activity and decreased formation of cyclic AMP? Well, there's less activity of protein kinase A, and remember, protein kinase A's job is to phosphorylate proteins. In this situation, protein kinase A's job within these principal cells is to phosphorylate the aquaporin 2 channels that are hiding inside of the vesicles. When they're phosphorylated, these aquaporin 2 channels can be inserted into kidney tubular cell membranes. Now, lithium and dimethylcycline interfere with the insertion of aquaporin channels. Less aquaporin channels in the cell membranes means that we're going to be absorbing less free water. Less water can be absorbed and more water will be lost into the urine. This produces a lot of dilute urine, so the concentration of the urine is low. Your patient will be peeing like a horse, and we call this polyuria. What else do you need to diagnose diabetes insipidus? So, losing a ton of free water will increase sodium concentration in the plasma. So we get an increase in sodium serum concentration. This is hypernatremia. This will also in turn elevate the plasma osmolality due to the definition of plasma osmolality. Because there's a loss of water that would dilute stuff in the plasma, but we're losing all of it, so therefore the sodium goes up and the osmolality goes up. So if your bipolar patient is on lithium, you should suspect nephrogenic diabetes insipidus if they're presenting with low concentration of urine, high sodium, high plasma osmolality, and they're peeing a lot. Another key thing is to look at the plasma osmolality, and it is usually greater than the urine osmolality. Now, switching gears completely, pretend you're teaching someone and describe SIADH. This is due to an excess of antidiuretic hormone or vasopressin causing way too much free water retention by the kidney, creating very concentrated urine, hyponatremia, and a low plasma osmolality. No one has quite figured out yet why these drugs, such as carbamazepine, cyclophosphamide, and SSRIs, cause the symptom, but it's been thought that it actually increases the body's sensitivity to ADH. So just remember that. Two important drugs, tenofovir and ifosfamide, these are both taken up by the proximal convoluted tubular cells and can actually cause the renal epithelial cells to malfunction and die. If you lose function of proximal convoluted tubular cells, so all these are knocked out, you start dumping amino acids, glucose, bicarb, and phosphates directly into the urine. So you're losing all these into the toilet. This is called Fanconi syndrome. Cyclophosphamide and ifosfamide are both broken down into a dangerous metabolite that we call acrolein. This is an aldehyde that depletes intracellular glutathione, again losing GSH or reduced glutathione. This makes mucosal cells of the bladder very susceptible to oxidative stress. Remember, reactive oxygen species, reactive nitrogen species. Eventually, the bladder mucosa gets inflamed and breaks down. So here's the mucosa, and it gets angry and all inflamed, and eventually you're going to expose the blood vessels that are within it or directly underneath it. They're going to break and bleed. You call this a hemorrhagic cystitis because there's inflammation, itis, of the cystic epithelium of the bladder, and because it's bleeding, you have to throw the name hemorrhagic in front of it to sound cool. How do you treat this? Give the patient something that will bind acrolein, this dangerous metabolite. What is that called? It's Mesna. Everyone loves this question because it's just easy to remember, or it's a rare thing. Boom, Mesna. Now, methicillin isn't used anymore because it was one of the first culprits in acute interstitial nephritis. So many people, though, are taking NSAIDs and furosemide that it is a potential question. Actually, we just performed a kidney transplant on a patient with renal failure secondary to acute interstitial nephritis from chronic NSAID use. So be on the lookout for chronic pain patients. In addition, be suspicious of this disease if the urinalysis shows a high level of eosinophils. So let's say that you started a 27-year-old white dude with primary hypertension on lisinopril 2 months ago. And now you're seeing him for follow-up. He says that he's had a dry, non-productive cough for the 2 months that you've given him this drug. He's tired of it. He's a Gunner medical student and he wants you to explain why. He raises his hand when he asks you the question. What do you say? Well, you tell him that lisinopril is an ACE inhibitor, which means that it decreases the angiotensin converting enzyme activity so that not only can we inhibit his hypertension from occurring, but unfortunately also are unable to break down bradykinin. So bradykinin accumulates because it also, ACE, breaks down bradykinin levels. You say, bradykinin is the cause of all your problems, dude. It sensitizes nerve endings within the airway and can even trigger bronchoconstriction. This is the root of your problems, bro. You then take his money and say, hey, here's an angiotensin receptor blocker, so get off the lisinopril and give him an ARB. Methotrexate, carmustine, bleomycin, busulfan, these are all chemo drugs, right? They cause direct pulmonary epithelial cell damage. All that damage triggers an intense inflammatory response that eventually will heal with fibrosis. We call this pulmonary fibrosis. This is a bad thing. On the other hand, nitrofurantoin and amiodarone, this is a pulmonary fibrosis secondary to a hypersensitivity-like reaction that initially starts off with a pneumonitis and then resolves with healing and fibrosis. We talked a lot about the muscarinic antagonist atropine a lot earlier in this chapter. Be on the lookout for other drugs that have a different primary mechanism of action, but also secondarily inhibit cholinergic receptors. What am I talking about? The prime time examples of this are tricyclic antidepressants, the first generation antihistamines, and antipsychotics. Sure, they have a different mechanism of action that you want the patient to experience, but secondarily, they can have a lot of anti-cholinergic side effects. What is a disulfiram-like reaction? So disulfiram right here is a acetaldehyde dehydrogenase inhibitor. It is used to treat chronic alcoholism by preventing the conversion of acetaldehyde to acetate. This leads to the accumulation of acetaldehyde. This is the molecule responsible for feeling like crap when you're hungover. All of the drugs listed here, guess what they do? Why do they cause a disulfiram-like reaction? Well, they also inhibit acetaldehyde dehydrogenase. In the setting of someone boozing, this can be quite unpleasant because their body starts to accumulate acetaldehyde because they're doing a good job and taking the drugs that we told them to, but they're also boozing at the same time, which is why they feel this disulfiram-like reaction, which kind of feels like you're hungover. Now let's keep going. At a physiologic pH of 7.4, aminoglycosides, particularly neomycin, take on a very, very positive charge. These highly charged molecules then strongly bind to negatively charged phospholipids of the proximal convoluted tubular renal epithelium cells. What are the proximal convoluted tubular cells going to do? They're going to take them in and say, okay, what is this molecule? And they take it in, and now it's inside the cell. Then they start accumulating these drugs within the cells, and that's how you get significant damage. Watch out for an elevated creatinine in a patient that recently started taking antibiotics such as neomycin. These are aminoglycosides. Important to remember that. Within the cochlea of the ear, aminoglycosides can bind NMDA receptors and induce a cytotoxicity. If a patient complains about this new onset ringing or tinnitus after taking a drug like neomycin, be careful and think about toxicity to the cochlear hair cells, or if the creatinine is elevated, be thinking about damage to the proximal convoluted tubular cells. Now, this drug is used all the time, vancomycin. It is used to treat MRSA or suspected MRSA. It is currently thought that when the proximal convoluted tubular cells of the kidney see this vancomycin, They work extra hard to actively pump it out into the urine. So they take it up and then they say, all right, into the lumen, into the urine you go. The problem is that they work so hard by actively pumping this drug into the urine that this increase in oxygen requirements can actually lead to the production of more reactive oxygen species. This oxidative stress is thought to be the underlying mechanism of vancomycin nephrotoxicity. Watch out for vancomycin nephrotoxicity in a patient with some sort of MRSA history or being treated with something, and also the risk of vancomycin oto or nephrotoxicity is increased if they're on an aminoglycoside such as neomycin. That is the one that's classically described. Now, cisplatin is a platinum-based chemotherapy drug. Platinum directly binds to purines within the cell. Because cisplatin accumulates within the kidney and the inner ear, there can be unintended damage to the proximal convolutubular cells and the cochlear hair cells. This is a highly testable drug because it has so many side effects. Amifostine is a free radical scavenger. So it looks for a reactive oxygen species and goes, bam, I'm going to take you out. It is given with some chemo drugs like cisplatin to decrease the risk of nephrotoxicity and ototoxicity. Sorry guys, I've tried to find a way to make these facts just more than memorization, but I failed. You just have to memorize these. You have to know the medications that induce or inhibit CYP450 enzymes because tons of patients are taking multiple drugs at all times. They're all important, unfortunately, so try to smash these in your head somehow. Now, CYP450 inducers and inhibitors are more of a step 2 kind of question, but if you do get a vignette on step 1 about these inducers and inhibitors, you better believe it's going to be related to the very important substrates of the CYP450 enzymes. This includes a patient that recently was started on warfarin for something like a pulmonary embolism or AFib. Other possible vignettes could be a female on oral contraceptives with a recent, like a positive urine pregnancy test because she was taking something like phenytoin for seizures, which was inducing the CYP450 metabolism of the oral contraceptive. These patients should always have their medications reviewed to ensure that the patient is not taking some drug that's going to be changing by increasing or decreasing the metabolism of an anticoagulant or contraceptive drug. Now, 3% of people that ever take a sulfa drug, ever, will have a side effect. 3% of any time that you've ever given a person a drug, they might have a side effect. That's pretty common and therefore high yield. Here's the most commonly used sulfa antibiotic. This is sulfamethoxazole. Here we see the most commonly used loop diuretic, furosemide. And here we have the first line therapy for hypertension, hydrochlorothiazide. All of these drugs, including the list right here, have something in common. They have these sulfonamide groups. When these sulfonamide groups are metabolized by the body, they create very, very reactive metabolites that like to bind and stick to proteins in the body that they're not supposed to. They act as a hapten. This is a bad thing. They can trigger an immune response by sticking to whatever proteins they want to. The most common reaction is a type 1 IgE hypersensitivity reaction that produces just rash and hives. We've all seen this. We've been tested on it. We've experienced it maybe. The reactive metabolites can also bind T cell receptors and cause a more of a delayed type 4 hypersensitivity like reaction where we get a CD8 positive T cell response that can be life-threatening. This is something like Stevens-Johnson syndrome, and if more body surface area is involved, we call it toxic epidermal necrolysis. A 23-year-old woman with a history of panic disorder and generalized anxiety disorder is brought to the emergency department after being found unconscious in her room by her parents. She is lethargic, can barely be aroused. Her parents are sure the only pills in the house are those prescribed by her psychiatrist. Vital signs normal, pupils dilated. She's normally reactive. The blood alcohol level is 100. Results of her urine toxicology are pending when suddenly she starts having episodes of bradypnea or slow breathing that cause her oxygen saturation to dip. What should the physician give to treat this patient's condition? Before you look at the answer choices, try to see what the vignette is telling you. You know this is a psych patient, right? They have some history of anxiety. You know that for anxiety, they can give benzodiazepines for that. Another key tip here is the neurologic exam. Note how the pupils are big, they're dilated, which should steer you away from opioid use, even though they're trying to trip you into thinking that it's opioids. The decrease in respiratory rate, right here, is the main reason that you were trapped into thinking that it's opioid overdose. But benzos can also cause CNS depression that includes changes in the respiratory rate. The correct answer is to give a benzodiazepine antagonist, flumazenil.